Okay, so welcome. And next, we're going to just sort of keep going on this theme of osteotomy techniques for left deformity. And again, there's many variations on osteotomy technique. And again, I've got a lot of material. I don't know if you'll have time to cover everything, but it's mainly just the flavor of what about osteotomy. So in simplistic terms, we want to know where to cut the bone, how to cut the bone, what shape of the osteotomy, how to obtain and maintain correction, right? And that goes for any osteotomy types. So where to cut the bone, right? What to consider. And again, there's like multiple courses, multiple sources of information. And depending on your level of experience and expertise, some of this may be too basic and some may be too advanced, but I'll just go to the basic stuff. Again, history and physical exam is important. Look at plain x-rays, draw your lines and angles, however you do it or however you learn to do it, and find the apex or apices of the deformity. This goes for both, frontal and sagittal plane, right? AP and lateral view. And then malrotation, I think for the most part, you can figure out clinically, right? Many different years. And then, other things that go in the equation is, what does the soft tissue look like? Is it a leg length difference? What is your experience and resource availability? But let me just show you a few examples of how this osteotomy rule applies, which is, let's say you've figured out where the apex of the deformity is, but for one reason or another, you end up cutting the bone away from that apex. Then, in order to line the two fragments together, you have to translate that distal fragment so the two line up. It's that simple, right? Same thing for supracollar, same thing for humerus, femur, tibia, everything. So, few case examples, right? Forget about all the details. Just look at the osteotomy location and translation, right? So, distal femoral valgus related to a premature physeal arrest, distal femur. And we did it gradually because he needed length. And look at the amount of translation that's needed to realign the mechanical axis, right? Same way you could use this principle for coxa vara. And don't look at the implants. Just look at, you could do the same thing with a blade plate with a medial offset, right? If your deformity is sort of periphyseal, close to the growth plate of the proximal femur, and you're doing a varus to valgus correction, you've got to medially translate, you got to laterally translate the distal fragment, right? Varus to valgus. If you're going to varus, then you have to medially translate. Okay, so pardon me. You don't need an offset when you're doing a varus to valgus correction of, a proximal femur. They need to laterally translate. Okay. Same thing with the distal tibia. Premature physeal arrest, shortening, you do the correction, that's a little bit too far translated, so then you correct that. And maybe this is not a perfect result, but the point is you do need some translation as you get further away from the physis, if the physis is where the problem is, where the apex is, right? So this is a patient from overseas from many years ago, but it's a very good illustration of how you can use that principle to your advantage and break the rule, right? So he was a pedestrian struck by on a motorcycle, had this bad skin rash, a perichondrial injury when he was 5 years old. He came 10 years later and had a 15 centimeter leg length difference and a lot of scarring around the knee. And the apex of the deformity was at the knee, right, with bad skin. And just in terms of, his injury, he had a perichondrial injury, the x-rays are fine. They kept doing all these osteotomies, but because it was like this growth plate Rang type 6 injury, there was no broken bone. It was just that the perichondrium had been injured and degloved related to a road rash. Anyway, and again, forget the device. But the point is, if you are doing your osteotomy above and below or wherever, away from the apex, you have to translate, right? So this is a good example where, because of bad soft tissues, we weren't able to do an osteotomy at the apex. So you can go to the more healthy part of the bone or the leg, but then you've got to translate so that in the end you got a straight leg. Now, of course, his knee is being fused from way back when he had multiple surgeries elsewhere, but at least we got him a straight leg. And then if you don't do that, then this is what happens. So this was a patient I saw in my prior practice, sent by an arthroplasty surgeon. This patient had like 6 prior surgeries and had medial compartment arthritis, primarily had Blount's as a child. And this was the error from prior surgeries, where they're trying to correct the angulation without fixing the translation, right? So you couldn't even put a total knee stem in the proximal tibia, because see how far that tibia is translated medially. So just to sort of, fix that, and of course, this were the days when they would pre-build the frames, which we actually don't do anymore. You could see how much lateral translation was needed just to get the proximal tibial plateau and the tibial shaft in one line, right? So this was uncovering all the iatrogenic deformities that were there before, when they were just treating angulation without translation. And, so she was like 10 years out, and now she was happy she actually didn't need a total knee. The last I saw her, which was 15 years post-op. Okay, that is where to cut the bone, then how to cut the bone, right? For the most part, if you're doing any kind of gradual correction, and even if you're doing acute correction, especially in children, respect the periosteum, because periosteum can do amazing things if you're nice to it. And if you use a lot of, power saws, you can create a lot of thermal necrosis. Plus, it can be unsafe in terms of adjacent structures. So, I think we have a lab on multiple drill hole osteotomies, and most of you know the concept. But you sort of weaken the bone by putting multiple drill holes at the assigned area, and then you complete the crack by doing an osteotomy. So it's low energy, less thermal necrosis, and bone hews good. Again, we're not going to go into all the details, but again, as you see, I'm a big fan of pre-op planning. You can measure all the numbers, angles, et cetera, but then you've got to position the patient appropriately related to their soft tissue dimensions, et cetera. And this is sort of the key slide on one way to do a drill hole osteotomy. And again, we'll look at it in details, but here we're looking at a proximal tibia. You could do the same thing for any bone, right? And a lot of the equipment that's needed is very easily available anywhere, right? You have a wire. So you can use a wire to sort of feel the underlying bone. Right? So that's sort of, step one. So you're not making incisions at areas where, you're off the bone. We'll not look at all the details, but then you can expose the bone a little bit, which you don't really need to in the femur and even in the tibia, but this is really partly for demo purposes, where you make an incision so you can see the drill holes, but you really don't even need to see the drill holes, especially if you have fluoroscopy, right? And then you can either have one single entry and then multiple exits, or you could just move things around to just weaken the bone. And a lot of times I will start the drill hole osteotomy, but not complete it. So I know where it's going to be at the pre-assigned location. And then I'll put fixation above and below based on what's needed. So I'm not, cheating and moving my osteotomy site at a different location because I put too many half pins where the osteotomy needed to be. So sometimes it's good to commit yourself and then work around it once you know where the osteotomy is going to be. So again, one way to do it. The one thing I must say is, and I've done this multiple times, where you think the bone's broken and it's not, because it's just sort of rotating. So you have to convince yourself by translating and making sure the bone's totally broken so that, if you're doing a gradual correction, it's not incomplete and you have to go back. I'm going to skip through some of this. Now, this is called reverse innovation, where something gets discovered in a resource-limited environment and then gets, adapted or adopted by in the high-income countries. And the jiggly saw osteotomy is a great example of that. It was actually first published in JPO, which, doesn't always happen. A lot of these never get published, but it was actually in the northwest frontier close to Pakistan. And, it's a jiggly saw osteotomy, then later got adopted by the Baltimore group. And I use it sometimes, not as often as I used to. And I'll show you an example where I think this really helped. Is, let's say if you've got an intramedullary implant that's already there. So this is a child with OI. It was one of my partner's case. He asked me to help out for the osteotomy. And they've got a lot of recurvatum, but he's got a nail in there. So you either try taking out the nail, or you can cut the bone around the nail. So I think a jiggly saw is a great tool to use for that kind of situation. So here we pass the saw, cut the back cortex, and then use the multiple drill holes for the front, and then did gradual correction and straightened out his bone. And then my partner did plating after the fixator was off. But this is also a good example where you can use multiple techniques based on what's needed. Right? So here we did a jiggly saw, gradual correction, right tibia. On the left side, he had valgus and malvocation. So here, and the side was, I think, a little longer. So we did a fixator-assisted proximal tibial osteotomy with derotation. And because it was valgus and we did a fair amount of derotation acutely, we did a perineal nerve release as well, but did an intramedullary kneeling after that. So I think the point is you don't always have to be wedded to a single technique. It depends on what's needed. Shape of the osteotomies, again, you could go all into all the details, but I think I'll give you a few examples. Like, you can do a biplanar correction just by the tilt of your cut, right? So here we're talking about a sagittal saw blade cut in an acute situation, which I guess you can do sometimes, which is an oblique plane cut. And this was popularized by George Rath from Sacramento for early onset glands, where you can correct varus and internal rotation based on the tilt of your saw blade and your cut. There's papers out there, there's trigonometric formulae, etc. And you can even plot it on a graph paper. So again, you don't need fancy tools, you don't need to be a mathematician. It's actually pretty straightforward. This we sort of saw earlier. You could do a dome osteotomy, same principles. Those principles are find the apex. If you can do an osteotomy at the apex, do it. Then you don't need to translate. If you're doing it away from your apex, you got to translate, right? So this is one where it's a growth plate problem, recurrent glands, and we're doing an osteotomy at the growth plate because she's got a tibial plateau that's depressed and as a bony bar. And so here you don't need any translation. You just do an opening wedge correction. You can put some bone graft under it and you can get a good result. And so then how do you obtain and maintain a correction, right? So this is sort of the classic, carpentry and gardening, right? You do an acute correction, you cut the bone and you fix it, or you do it gradually over time and you nurture it. So here's a patient, mildly symptomatic bilateral genovarum, where, One side, we did a gradual correction. He was happy, but he's like, I don't like the fixator. So other side, we did an acute correction with a plate and a bone graft. And actually, he was happier in the end on the X-ray side for some reason, but he didn't like the journey when you were going through that. So I think it's one of those where there is no one good answer. There's more than one way to do it. And it depends, again, on all those factors. But definitely, if you're doing an acute correction, large deformity, you're going to have issues may have issues with neurovascular issues. So you can preempt it by doing the prophylactic, limited, give a compartment fasciotomy, put a drain in, don't put a tight cast, etc. So this is another patient who I'm showing you different techniques. And the point again is not to just show you something fancy, is to stimulate you to use something indoor environment, let's say using a sine nail instead of another type of device. So 16-year-old hypophosphatemic rickets had a guided growth plate treatment at other centers prior, were short on the right side, had a multi-apical, multi-planar deformity, procurvatum and distal varus. And then the tibia was also in varus internal rotation and was short. So fixator assisted, 2-level correction. You corrected in both planes and then do gradual correction of the tibia with some lengthening. And then on the other side, she wasn't that bad, but she was in a little bit of varus despite what the bone looks like. If you did all the analysis, it's a 2-level deformity. And then a significant procurvatum on the distal femur, a little bit in the tibia. So here, instead of going antegrade, we went retrograde and then did gradual correction of the tibia. So I think the point is you could achieve this so many different ways, but you just have to think about how to do it. And you don't always have to use, multiple drill hole osteotomies, etc. This is a case where we used clamshell osteotomy, meaning and this is a great technique, especially if you don't have fluoroscopy or you're limited fluoroscopy, you could just, as long as you don't have a deformity around the joint, so in the femur, if you don't have any sort of periarticular deformity around the hip and the knee, and all the deformity is complex and is like a large bow in the mid shaft or the central 2/3 of the femur, I think this is a good technique. It does involve a little more blunt loss, and you basically make drill holes on the far cortex, on the near cortex, and basically fillet open the bone, but you leave the periosteum and the soft tissue attached on the far side, and then you could just put a standard nail, be it a sine nail, Kunchner nail, any kind of nail, and it
Does it go into non-union sometimes? You left it open?
Well, not really, because you're keeping the periosteum and the soft tissue attached. So you sort of use it like a clam shell. So you basically do, again, multiple drill holes. You're not using that much saw, a little bit, but mostly it's multiple drill hole osteotomy, so low velocity, and then you just pry it open, and mostly not. And it's been described. I haven't done it for the tibia, but there are case reports for post-traumatic deformities in the tibia with clamshell. So yeah, I think for the most part it works well, especially if you like nails, I think, and you don't have a periarticular deformity, it's actually a good thing. But you got to think about blood loss. And just, I know we are short on time, so I'm not going to bore you with too many things, but just to say that sometimes you have to think biomechanics and the sagittal plane. This patient, and you may still see some post-polio patients. She was not a post-polio, but had a childhood femoral nerve palsy. And I think the point is that if you have weak or no cordyceps function, don't lengthen the bone without straightening the sagittal plane or, keeping the knee in the extension. Otherwise, they're going to lose their ability to independently undulate. So here, while she was short, she was in valgus, she had really no quads function. So first what we did is with all the planning, did a fixator-assisted plate fixation with some supracannular hyperextension, corrected her valgus too, and then came back and then did a proximal lengthening. And, you don't need a magnetic nail. You could do it with a lengthening over a nail. You could use it with a monowave. You could do an X-fix, anything you want. And this is a final case, 18-year-old, recently seen with, bad gene valgum, perhaps related to some metabolic bone disease, but undiagnosed. And, so many deformities, but don't get overwhelmed. You could still dissect it out. And I think the point of this case is you don't need to do everything in one sitting. You can stage it. And sometimes you don't have the luxury because patients and families can't afford multiple things. But again, not to go into the details, but he did have some a little bit 6-7 degrees of distal femoral valgus, which we corrected acutely with a plate. Did a nerve release, peroneal nerve release, and then came back. And again, he had deformities both in the distal and the proximal tibia. And so this is a good example where if the apex is at the joint and you're going to do your osteotomy away from the joint, you've got to translate it, right? And how much you translate is based on the distance between the two lines, which is your planned, normal angle and your current angle. So the further you go from the apex, the more that need for translation will be in distance. That makes sense? So this is another way to plan. And then, so he's got a straight leg, and now you can see he's walking nice and straight, at least early on. So I think in summary, same thing. You got a pre-op plan, especially in children and adults, actually even more so. You got to think of the periosteum because in adults, there's a thinner periosteum. It's even more important to preserve it, right? And follow the deformity principles. Implants do evolve over time, again, like we said earlier. But if you're going to adopt a new technology, master what are the complications with that technology or that technique. I just had my, actually between our talks, my patient that I was doing a lengthening with a nail, magnetic nail, the nail broke. So, it happens, right? So there's nothing that's foolproof. And then again, if possible, stage procedures as we thought.